Good morning, everybody. We have a busy day or two ahead of us, and I just want to say our goal is to try and stop about noon, and it will continue tomorrow on the unfinished numbers of bills we're going to mark up. So the committee is going to come to order. At the conclusion of opening statements yesterday, the chair called up H.R. 5050, and the bill was open for amendment at any point. And I would like to call up the bipartisan manager's amendment offered by myself and Mr. Pallone. If the clerk will read the title.
Amendment to H.R. 5050, offered by Mr. Upton.
The amendment will be considered as read. The staff will distribute the manager's amendment and will recognize myself for brief statements in support of the amendment. Basically, this has four main parts to perfect and clarify our language in the bill. First, perhaps one of the more controversial sections, emergency orders. In similar fashion to our friends on the Transportation Committee, remember this is a bill that both committees have under their jurisdiction, we clarified the conditions that would allow PHMSA to issue an emergency order, strengthen the definition of imminent hazard, and align the procedures for reviewing an agency decision with those that govern the transportation of hazardous material. Section is much stronger and much tighter, but we've also agreed to further clarify a few points in the report language. It is our intent for PHMSA to consult with owners and operators of pipeline facilities before issuing an order. It's also our expectation that PHMSA will issue final regs to carry out this new authority as quickly as possible. The temporary regulations are just that, temporary. Second, I'm proud to say the manager's amendment also includes a new section jointly authored by Mr. Latta and Mr. Welch to find ways to streamline federal regs for small propane facilities that serve communities with affordable and reliable energy. I want to commend both these gentlemen for being leaders. They represent states that have certainly felt the impact of propane shortages in the winter. Michigan is one of those, by the way, and they also share a commitment to find workable solutions to increase the supply and lower the cost of this valuable fuel, particularly for those in rural areas. Third, the amendment strengthens a study to look at the integrity management plans for oil pipelines, an issue that Ms. Capps and others on this committee have been focused on. I share Ms. Capps' concerns. We spoke last week that some pipelines should be inspected more frequently than they are currently required. And finally, our amendment contains language for Mr. Engel that reaffirms PHMSA's responsibility to consider cyber and other threats to our national security when issuing minimum safety standards for liquefied natural gas pipelines. It's important to remember the role that energy security plays in national security. PHMSA has had an important responsibility here for sure. So together, these changes amount to significant gains for pipeline safety. And with passage of this amendment and the underlying bill, we are indeed giving PHMSA the tools that they need to get the job done. And I would yield back on my 5 minutes and recognize the gentleman from New Jersey for 5 minutes.
I'm sorry. Thank you, Mr. Chairman. I move to strike the last word in support of the manager's amendment. As I noted in my opening statement last night, the legislation before us today is a reasonable compromise that makes incremental progress in pipeline safety. The amendment before us similarly reflects that spirit of compromise. The amendment addresses a number of concerns raised by Democratic members during the Energy and Power Subcommittee's consideration of the bill. It also addresses issues raised by Republican members of the subcommittee during that markup. In particular, there is language responding to concerns raised by Representative Capps and others over recent liquid pipeline accidents, such as the Plains All-American failure in California last year. There's also a provision responding to issues raised by Representative Engel regarding the need to consider national security and cybersecurity in setting minimum safety standards for liquefied natural gas or LNG facilities. In addition, the amendment adds language developed by Representatives Latta and Welch requiring the Secretary of Transportation to enter into an agreement with the National Academy of Sciences Transportation Research Board to conduct a review of propane gas pipeline regulations and industry best practices, among other things. And finally, the amendment makes changes to the emergency order authority provided to the Secretary of Transportation in Section 15 to address concerns raised by Republicans and industry. While I would have preferred to leave the emergency order language untouched, these changes resolve a number of those concerns by conforming the language in our bill to that in a pipeline safety reauthorization reported by the Committee on Transportation and Infrastructure by voice vote last week. So this amendment is a true compromise that I hope makes it possible to move quickly to passage with the support of all members on both sides of the aisle of this committee, and I urge my colleagues to adopt the amendment, and I yield back.
Chairman yields back.
Oh, I'm sorry. I'd like to yield to our ranking member, Mr. Rush.
I want to thank you, Ranking Member, for yielding. Mr. Chairman, I just wanted to reiterate the point I made yesterday in my opening statement that this bill represents a bipartisan compromise that resulted from good faith negotiations between the two sides. I would like to applaud you, Mr. Chairman, and Chairman Whitfield, and the Ranking Member Pallone, and myself. And I also want to commend the committee staffs on both sides of the aisle for the hard work on this bill. Mr. Chairman, I really want to lift up Mr. Green, Mr. Tonka, Mr. Engel, Mr. Pompey, and Mr. Latta, to name a few of the committee members who did extraordinary work on this bill. Mr. Chairman, I would like to highlight in a special way the work of Mrs. Capps and her staffs for their valuable contributions to the underlying bill and the manager's amendment. Ms. Capps has been extraordinary in her leadership. She's been enlightened, and she's really been a breath of fresh air in terms of this whole process. And I really want to commend her, and I'm sure her constituents will be proud of the contribution that she has added to this bill in hopes of preventing another catastrophe like the Plains America spill that ravaged parts of her district last year. Mr. Chairman, with that, I yield back to the ranking member.
Let me just taking back my time. I know we're all saying all these great things about Lois Capps, but it's really true. Without her making this reauthorization better, it really would have not have been possible without the time that she put into it. So again, I want to thank her in particular. Both of us want to thank her. I yield back, Mr. Chairman.
Gentleman yields back. Chair to recognize Mr. Whitfield, the Chairman of the Energy and Power Subcommittee.
Thank you very much, Mr. Chairman. I would like to ask a question of legal counsel on this matter. We're giving the Secretary the authority to issue an emergency order if he finds an imminent hazard. And then it's my understanding that there is an opportunity for review under Section 554 of Title V. And if the department receives this petition for review, do they have a certain length of time in which to act? And if they do not act, what are the consequences?
Yes, sir, they do. Upon petition for review from an entity subject to and adversely affected by an order.
Is your mic on?
The mic is on. So if a petition for review has not heard within 30 days, then the order expires. It's no longer valid.
Okay, I just wanted that clarification, Mr.
Gentleman yields back. Other members wishing to speak on the manager's amendment? Gentlelady from California, Ms. Capps.
I'm in between microphones. But I wanted to strike the last word. I appreciate the comments of my colleagues, Chairman Upton, Ranking Member Pallone. This markup is an incredibly important topic. The bill we are considering today marks such a good step forward to strengthen the safety standards in place for our nation's pipeline hazardous materials infrastructure. Many of us share this conviction about the need to address this, and far too many of us have been impacted by failures in our oil and gas infrastructure. These oil spills, gas leaks, facility explosions are a threat to public health, the environment, and our local economies. And of course, it's not an accident. As long as we rely on fossil fuels for our energy needs, it's only a matter of time till we are faced with another such incident, which is why we need to find ways to minimize the risks associated with this industry, maximize the safety standards, learning from past accidents, ensuring we are instituting the best practices. In the past, we've not always heeded this, but today the bill before us attempts to correct some of these missed opportunities. I'm pleased the bill includes language to clarify the term, which has been referenced, high consequence area, and a provision to study the underlying causes of corrosion and best methods to prevent it. And as has been noted already, both of these address problems that were highlighted when the Plains pipeline spill occurred in my district last May. Immediately after the spill, we were faced with questions about whether the Gaviota Coast was in fact a high consequence area and how that uncertainty would impact the response to the spill. Language in this bill will make it clear that this region, but also other sensitive coastal regions around the country, are indeed high consequence areas and subject to more frequent integrity in assessments and additional risk control measures. Similarly, the corrosion study language included in this bill will address the heart of the cause of the Plains spill. And if we're going to minimize the risk for future pipeline failures, we must have a better sense of what causes corrosion and how to best prevent it. The bill also includes an emergency order authority, which provides PHMSA with authority to address industry-wide or systemic problems that require immediate consideration. These are important provisions that will make a real impact on pipeline safety. There is still, of course, room to strengthen this bill, and I'm happy to report that the manager's amendment includes some necessary provisions to do just this. In particular, the amendment addresses the need to review pipeline inspection frequency. There is bipartisan agreement that there are pipelines, such as those highlighted in Section 12, that require more frequent inspection than existing standards. However, exactly how to determine which pipeline should be included continues to be a contentious topic. The manager's amendment would set the stage to gain a better understanding of how to best set assessment frequency. Some will say this is not the perfect bill. I agree, but this compromise will strengthen safety standards, and for that reason, it should be supported. I want to thank the majority for negotiating in good faith so that we were able to arrive at a bipartisan agreement, and also Ranking Member Pallone for his commitment to getting the strongest possible legislation. This is a bill that's being watched very carefully by my community, very critical to its future. I urge the committee's full support. I'm yielding back.
Gentlelady yields back. Other members wishing to speak on the manager's amendment? Gentlelady from California, Ms. Eshu, is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank you and Chairman Whitfield and our ranking member, Mr. Pallone, for bringing this bipartisan bill forward. This pipeline safety issue is one that continues to be a top issue in the county that I reside in California, San Mateo County. And you've heard me speak on many, many occasions about what took place on September 9th, 2010 in the community of San Bruno, where a natural gas pipeline explosion took place. It killed 8 people, it injured dozens, and it destroyed 38 homes. If you were to see the area, it really would take your breath away in terms of what this explosion did. Since San Bruno, we know that there have been several other oil and natural gas pipeline failures around the country, including the Plains All-American Pipeline, which Congresswoman Capps has spoken about, where it ruptured in Santa Barbara last year, and it also caused the spilling of thousands of gallons of crude oil into the Pacific Ocean. Now, following San Bruno, this committee crafted bipartisan legislation to require PHMSA to address specific issues that contributed to the disaster, including automatic and remote shutoff valves, which is very important, enhanced safety requirements for pipelines in high-consequence areas, and requiring the testing of pre-1970 pipelines, which are grandfathered from certain pipeline safety regulations. And this is a very, very important area because it has this testing of grandfathered pipelines is so critical. The NTSB concluded in its review of the San Bruno case that hydrostatic testing of grandfathered pipelines would have likely exposed the defective pipe that led to the actual pipeline failure. And PHMSA has been slow to implement the requirements of the 2011 legislation, but last month it did propose important regulations that would address many of the critical mandates in the 2011 bill and the NTSB's recommendations following San Bruno. So I'm very pleased that this bill is before us today. My only concern is, with the bill, is that I think it should include the language that clarifies the ability of private citizens to force PHMSA to perform its required duties. Following the San Bruno explosion, the City and County of San Francisco sued PHMSA for failing to enforce pipeline safety standards in the years leading up to the explosion. So I just want to end with asking a question. Why wasn't this, and I really don't know, why wasn't this included in the bill? Because I think the language should be restored. We had it before, but it's missing now.
The answer is we just didn't come to an agreement on it, but it was on the table, and at the end, as we put it together, it just didn't make it through.
But what was the reason for it, though?
The gentlelady yield.
I mean, that's what
I wasn't in the negotiations, but my guess is that we don't have interveners in every pipeline in every direction throughout this country to stop the flow of crude oil and basic products. I think that's probably why. There is always a fear about the environmental left using every means to stop fossil fuels. So I think my guess is we don't want to give them multiple bites at the apple to just stop the flow, where we know there's been tragedies, especially with natural gas, but the public doesn't really understand how much product goes, how many thousands of miles of pipeline there are in this country. And so I think that is probably the answer. We fear intervention by the liberal left and the environmental community to shut down the flow of crude oil through pipelines.
But this is not, if I might reclaim my time, this is not an environmental question. This is about what PHMSA is required to do, what we require them to do, and if they don't, then citizens will be able to take action. So I don't know.
If the gentlelady yield, I think that's...
I don't know liberal, environmental.
No, citizens are citizens. So they could be intervening on behalf of a group that they belong to. So I think I'm just answering the question that you posed.
Time is
Yield back.
gentlelady yields back. Other members wishing to speak on the manager's amendment? Seeing Mr. Engel for 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word. I am pleased that we're working on legislation to improve the safety of our nation's pipelines and pipeline regulation by PHMSA. I want to first of all thank you, Mr. Chairman, and Mr. Whitfield, of course, our ranking member, Mr. Pallone, and Mr. Rush, for all coming together and really putting forward a good piece of legislation that's a good compromise and something there for everybody and very important, moving in the right direction. I'm particularly interested in ensuring that national security and cybersecurity receive appropriate action in the siting, operation, and maintenance of pipelines. Hostile actors are looking for vulnerabilities in our infrastructure every day. In fact, the Department of Justice recently indicted 7 Iranian hackers for their role in a cyber attack on a dam in Rye, New York, on the border of my district, just outside, and we have to be vigilant about these threats. For the last 6 months, I've worked with a group of New Yorkers concerned about the construction of a large natural gas pipeline alongside an old and troubled nuclear power plant, Indian Point. I was shocked to discover how little attention was paid to matters of national security and cybersecurity throughout the regulatory process. When citing the pipeline, nobody even bothered to ask the Department of Homeland Security whether its proximity to a leaking nuclear power plant made it a bigger terrorist target. That, in my opinion, is not vigilance. As a result, I've worked with colleagues on both sides of the aisle to include changes in the manager's amendment and additional language in the committee report implicating consultation with DHS to increase our diligence when it comes to the national security and cybersecurity of our pipeline infrastructure. Our actions here today are a step in the right direction, but our efforts to defend our infrastructure are far from complete. I look forward to working with members of this committee on additional legislation that addresses this issue in greater detail. I thank you again, Mr. Chairman, for everything you've done in this regard, and I yield back.
Gentleman yields back. Other members wishing to speak? Gentleman from North Dakota.
Thank you, Mr. Chairman, and I'm going to support the manager's amendment, and I'll certainly help get the bill to the floor, but I do have some concerns. I think the manager's amendment is fine as far as it goes, and I should state, too, having been a pipeline regulator for a number of years, I have to tell you, I like PHMSA a lot. I think they do good work. I think they're understaffed, but their problem is not that they don't have enough authority. And when I came here, I didn't come here to give more authority to the bureaucracy. I came to try to roll back the bureaucracy's authority and then give them the resources to do the job that they have to do. I think this bill gives them some unbridled authority. I would prefer, might help answer Ms. Ashu's question about why certain language isn't in the amendment or in the bill. This issue of who can be affected, who can be offended, is not a trifling issue. If we open that can of worms up, of course, we could see all kinds of opportunity for mischief that has nothing to do with safety, and I think Mr. Shimkus answered that very well. I'd like to see more explicit reference to the pre-consultation of industry, for example. I would like to clarify or remove the adversely affected by language. I'd like to clarify who can and who cannot, who can and cannot have standing. But that said, those are things that aren't to my clarity or my liking. But I would also say this, as noble as compromise is, and I think it's a noble goal in a legislative body, I'd be all for compromising if we were rolling back regulations and power from the bureaucracy. But we're adding to it, and in every compromise we're still adding to the bureaucracy, and that concerns me. So I had an amendment that adds a few things that I'm going to not offer later this morning, but I did want to express those concerns and hope that as this gets to the floor, and as we look to bring one of the two bills, either the T&I bill or this one, to the floor, that we can fix it so that it's a little more pro-development and pro-energy security. With that, I yield back my time.
Gentleman yields back. Other members wishing to speak on the manager's amendment? The gentleman from California is recognized.
First, I want to thank you, Mr. Chairman, for working with me on the language to provide additional oversight, that of a cost-benefit analysis at OMB and PHMSA. Although I think that the current structure is somewhat duplicative and can slow the PHMSA ability to move forward quickly, the language we worked on is a step in the right direction, and I hope that we can keep this language in the bill as we merge with the T&I's version of the bill. I also like to talk about lost and unaccounted for gas within the transmission and distribution system. This just doesn't refer to leakage, as there are more than a dozen different factors that can affect unaccounted for gas. However, as we talk about pipeline safety and how to best improve our nation's aging infrastructure, we can't afford to ignore this issue. One of the best ways for us to get things right is to have the best available data and science. The EPA has said that no studies exist that accurately define the percentage of lost and unaccounted for gas. The EPA is just beginning to learn how little it actually knows about leaks in the oil and gas sectors. We're about to pass a bill that impacts hundreds of thousands of miles of pipeline within the U.S., and we're not addressing lost and unaccounted for gas. This issue deserves additional consideration within our committee, and I hope to work with the chairman on that. Again, I thank the Chairman Upton and Ranking Member Pallone for the Safety Act, and I yield back.
Gentleman yields back. Other members wishing to speak on the manager's amendment? Seen none, the vote occurs on the amendment offered by Mr. Upton and Mr. Pallone. All those in favor will say aye. Aye. Those opposed say no. In opinion of the chair, the ayes have it. Amendment is agreed to. Are there other bipartisan amendments to the bill? Are there other amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 5050 as amended to the House. All those in favor will say aye. Aye. Those opposed say no. The ayes appear to have it. The ayes have it, and the bill is favorably reported. Chair now calls up H.R. 4641 as amended by the Subcommittee on Health and asks the clerk to report.
H.R. 4641, to provide for the establishment of an interagency task force to review, modify, and update best practices for pain management, prescribing pain medication, and for other purposes.
So without objection, the first reading of the bill is dispensed with. Shh. The bill will be open for amendment at any point.
Mr. Chairman, I have an amendment at the desk.
Gentlelady has an amendment at the desk. The clerk will report the title of the amendment.
Amendment to H.R. 4641, offered by Ms. Brooks.
And the amendment will be considered read. The staff will distribute the amendment, and the gentlelady from Indiana is recognized for 5 minutes in support of her amendment.
Here we go. Thank you. Thank you, Mr. Chairman. I want to thank the chairman for continuing the bipartisan momentum that we started last week by swiftly moving this bill and the accompanying addiction bills through the full committee process today. While we are moving quickly on this particular package, the committee has meticulously investigated this issue over the past year with multiple hearings and expert witnesses, and the result is a package of solutions focused on prevention and treatment that will help those facing addiction and their families deal with this growing epidemic. H.R. 4641, which I introduced with my colleague Representative Kennedy, ensures that the recently released CDC guidelines for opioid abuse are updated and reviewed regularly. Every year, 260 million opioids, or one for every single United States adult with 20 million to spare, is prescribed in America. We need to make sure that prescribing physicians, pharmacists, first responders, law enforcement, and most importantly, family members of addicts have the best guidance, support, and resources to be successful. Our bill will ensure that opioid prescribing practices are reviewed, modified, and updated where needed by an interagency task force and expert stakeholders from the prescriber, patient, addiction, and recovery community to reflect best practices going forward. In the course of this debate, I've heard from many of my colleagues organizations who've demonstrated expertise in this field that would both enhance the task force's final product and ensure greater stakeholder buy-in. So I'm happy that the amendment before us today does that by adding hospitals, pharmacies, state medical boards, and others to the prescriber task force. If we're going to start solving this very difficult problem, we need a diverse set of ideas representing different viewpoints to an all buy-in to the solution. And this amendment draws in more experts, enhances the tenor in the conversation, and broadens the potential impact of our task force's work. And I urge my colleagues to support this amendment and the underlying bill. And
Would the gentlelady yield? Ms. Brooks?
Yes.
Back here, behind you. Yeah, I just want to add just one of the most moving meetings I had with a constituent was her fear of us moving too quickly. And she wasn't representing an association. She came in because she's a severe arthritis, chronic pain, and her fear is she's going to lose access to pain medicine that allows her to live somewhat of a normal life. She made 3 points, and it's one that I pretty much remember. Chronic pain is chronic pain. It's never going to go away. They're always going to have it. And that because of that, she's dependent upon pain-relieving medicine to have her live as normal a life as she can. But that doesn't mean she's addicted. So I keep those 3 things in mind as we move forward. We've got to be concerned about those people who are in chronic pain. They need this to live a normal life. Without this, they are in a homebound, hospitalized, or they don't add to the society, the community anymore. So I appreciate that and the focus, and I would just plead for those who suffer from chronic pain that we need to be very, very careful that we don't scare doctors and physicians away from prescribing this to our constituents. And I yield back to my colleague from Indiana.
Gentlelady yields back. Other members wishing to speak on the amendment? The gentleman from Texas, Mr. Green.
Mr. Chairman, I want to thank both our colleagues, Congressman Kennedy and Congresswoman Brooks, for this legislation. And I think this amendment's an improvement. There is some concern, and I'll follow up my colleague from Illinois about, I represent a blue-collar district. There are people who work really hard outside, and they get injured. And some of them are really getting along, and if they didn't have the pain medication. But I do want to make sure that I think this legislation is good, but also that the amendment makes it improved so we can make sure we can get the dosage level, and because we do have an addiction issue in our country, and whether it be in urban areas or rural areas. So, but I'm glad this bill's here, and thank you and Senator Representative Kennedy for doing it. I yield back.
Gentleman yields back. Other members wishing to speak? Gentleman from West Virginia, Mr. McKinley.
Thank you, Mr. Chairman. Chairman, striking the last word, Mr. Chairman, I appreciate the sponsor of this amendment, Representative Brooks, for working with us to include in her amendment the perspective of rural communities. Mr. Chairman, drug addiction and opioid abuse are a grave and growing concern all across America. But for the most part, in the last 2 decades, the deaths have resulted from opiates have quadrupled. However, if we're going to be successful, we must make sure that we're just not confronting this problem in our big cities, but also in rural America. While addiction is on the rise throughout the United States, the greatest concentration of misuse appears to be in rural areas, much like West Virginia, which has the highest rate of youth drug overdose deaths in this country at 12.6 per 100,000, almost double the national average. One reason the fatality rate is so high in West Virginia is the demographics of our state. Rural America is not the same as big cities. Take, for example, Tucker County, West Virginia, a population of less than 7,000 people living in a land area of 400 square miles. It's twice the size of Chicago, the landmass of Chicago. But yet they don't have a hospital, and they only have 2 ambulances for the entire county. These rural homeowners are concerned. Imagine if you're a mother or a father or a grandparent of a child who's overdosed on opioids there. Your options are limited. If your child does not receive the proper care and treatment within that medical golden hour, the chances of a positive outcome dwindle. For families living in rural communities throughout America, this amendment gives them a voice on the task force by including a representative from the Health Resources and Services Administration Federal Office of Rural Health Policy. This is important. It provides a unique set of challenges, and it is important that they have a voice on the task force looking to combat drug abuse and addiction. I yield back my time.
Gentleman yields back. Other members wishing to speak on the Brooks Amendment? Seeing none, the vote occurs on the Brooks Amendment. Those in favor will say aye. Aye. Those opposed say no. Opinion chair, the ayes have it. The ayes have it. The amendment is agreed to. Are there further amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 4641 as amended to the House. All those in favor will signify by saying aye. Aye. Those opposed say no. The ayes have it. The ayes have it, and the bill is favorably reported. The chair now calls up H.R. 4978 and asks the clerk to report.
H.R. 4978, to require the Government Accountability Office to submit to Congress a report on neonatal abstinence syndrome in the United States and treatment under Medicaid.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. Are there any bipartisan amendments to the bill? The chair would recognize the gentleman from Pennsylvania, Mr. Pitts.
Thank you,
As
Mr.
amendment at the desk. Clerk will report the title.
3.
Amendment to H.R. 4978, offered by Mr. Pitts.
And the amendment will be considered as read. The staff will distribute the amendment, and the gentleman is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. This is a bipartisan amendment offered by myself and Mr. Yarmouth concerning containing two common sense measures. First policy would encourage the continued development of abuse deterrent formulations of prescription drugs by exempting these formulations from the definition of line extension when calculating the Medicaid rebate. Today, due to a drafting error in current law, such formulations are subject to a higher rebate under the Medicaid program than Congress intended. The President's fiscal year 2017 budget proposed to correct this error, noting such a change would, quote, incentivize continued development of abuse deterrent formulations, end quote. The FDA has said that it, quote, considers the development of these products a high public health priority, end quote. Since abuse deterrent formulations represent a critically important tool in the federal policy toolbox, this policy change will help ensure that there is continued investment in these technologies, which will help reduce the number of patients who abuse opioid drugs. The second policy in this amendment is a common sense measure from the President's fiscal year 2017 budget that would protect from disclosure the program integrity algorithms used to combat fraud in Medicare, Medicaid, and CHIP. Today, the mathematical algorithms that CMS uses in Medicare are vital to uncovering fraud, waste, and abuse. But if various aspects of these anti-fraud tools were to become public, fraudsters could utilize the information to harm the program or beneficiaries. And this policy would protect taxpayers, save dollars by preventing the details of anti-fraud efforts from being disclosed. These two policies are common sense, they're bipartisan, good government policies that help protect patients and taxpayers. I urge my colleagues to vote for the amendment and yield back.
Gentleman yields back. Gentleman from Kentucky is recognized.
Thank you, Mr. Chairman. I'm very pleased to join Mr. Pitts in offering this bipartisan amendment. Medicaid beneficiaries are at the front and center of the opioid crisis. Unbelievably, though, our nation's most vulnerable populations are twice as likely to be prescribed opioid drugs as compared with the general population. Moreover, Medicaid enrollees account for 45% of overdose deaths and have 6 times the risk. I'm proud of the work that the Medicaid program has done with states over the last year to promote innovation and comprehensive substance abuse treatment strategies and to address the overprescribing of opioids to Medicaid beneficiaries. However, this amendment builds on those efforts and consists of 2 common-sense bipartisan policies. These policies will incentivize the development of abuse-deterrent opioid drugs and will preserve and protect CMS's highly advanced program integrity algorithms that are a key part of our efforts to fight fraud in Medicaid, Medicare, and CHIP. We must promote the development of abuse-deterrent formulations of opioids while aggressively pursuing efforts to combat fraudulent prescribing and dispensing, as well as so-called pharmacy shopping by those suffering an opioid addiction. This amendment addresses both concerns, and I urge my colleagues to support it. I yield back.
Other members wishing to speak, Chair would recognize the gentleman from New Jersey for 5 minutes.
Thank you, Mr. Chairman. I just wanted to say a few words in support of this amendment. Nationwide prescription drug abuse increased dramatically in the past decade, and the Medicaid program is at the center of the opioid crisis. It's, as some of my colleagues have mentioned, as we debated this opioid crisis in committee, Medicaid participants are twice as likely to be prescribed painkillers as their privately insured counterparts and account for 45% of overdose deaths and have 6 times the risk of an overdose death. And these are, pretty eye-opening statistics. I want to commend the administration's work to address the opioid crisis in the Medicaid program. And the Medicaid program has done a huge amount of work with states over the last year to promote comprehensive substance abuse treatment strategies and address overprescribing of opioids to Medicaid beneficiaries. However, this amendment builds on those efforts and consists of two common-sense bipartisan policies. These policies will incentivize the development of abuse-deterrent formulations of opioid drugs and will preserve and protect CMS's highly advanced program integrity algorithms that are a key part of our fraud-fighting efforts for Medicare as well as Medicaid and CHIP. And both policies were recommended in the President's budget, and I support this amendment. Again, another example of our bipartisan work here. Thank you. I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by Mr. Pitts and Mr. Yarmouth. All those in favor will say aye. Aye. Those opposed say no. Opinion of the chair, the ayes have it. The amendment is agreed to. Are there further amendments to the bill? Seeing none, the vote question now occurs on favorably reporting H.R. 4978 as amended to the House. All those in favor will say aye. Aye. Those opposed say no. The ayes appear to have it. The ayes have it. The bill is favorably reported. Chair now calls H.R. 1818 and asks the clerk to report.
H.R. 1818, to amend the Public Health Service Act to provide grants to states to streamline state requirements and procedures for veterans and military emergency medical training to become civilian emergency medical technicians.
And without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. Are there any bipartisan amendments to the bill? Are there any amendments to the bill? The chair would recognize the gentleman from Illinois, Mr. Kinzinger.
Thank you, Mr. Chairman. I have an amendment.
And the clerk will report the title of the amendment.
Amendment to H.R. 1818 offered by Mr. Kinzinger.
And the amendment will be considered as read. The staff will distribute the amendment. And the gentleman from Illinois is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. This is just a simple technical correction to change the title from 2015 to 2016. I want to personally thank Congresswoman Capps for working with me on this for a long time, and thank the committee. This is a good bill for veterans and for rural communities that find themselves having a hard time recruiting EMTs for their fire departments or their hospitals. And I would request the committee's support on this and thank the chairman for considering it, and I yield back.
Gentleman yields back. Chair would recognize the gentlelady from California, Ms. Capps.
Thank you. I wanted to have a moment to thank my colleague and for working with me on this, and me for working. Well, we worked together on the Veteran Emergency Medical Technician Support Act. I just want to say why this bill is so important to me. We know that we have some of the most highly trained medical professionals in the world while they are in the military. These men and women receive the best technical training in emergency medicine, and it's all tested on the battlefield in very extreme circumstances. But when they return home, these medics return back to civilized or so-called civilized life or civilian life, and they attempt to apply their skills to work in the civilian EMT sector. They are forced to start at square one, as though they had never had any experience in the battlefield. Repeating coursework isn't just a waste of time, it's also very expensive. So similarly, when an EMT leaves to serve in the military, their civilian certifications can lapse while they are away. We have a tremendous need for qualified emergency medical technicians in this country, but this discrepancy is keeping qualified veterans out of the civilian workforce. We need these valuable medical personnel in our communities, especially as we now face this opioid crisis. The two topics go together. So we need to pass this bill because it provides a small but meaningful step to address these problems. Vets EMT will help our states streamline their certification processes so that the military medical training can be accounted for when applying for civilian licensure. So I again urge full support for this bill to help our talented military men and women join the health workforce and continue to make a difference at home after doing such tremendous work abroad. And I'll yield to anyone, or I'll yield back. I yield back.
Gentlelady yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on favorably reporting H.R. 18 as amended to the House. All those in favor shall say aye. Aye. Those opposed say no. Ayes appear to have it. The ayes have it. The bill is favorably reported. Chair now calls up H.R. 4981 as amended by the Subcommittee on Health and asks the clerk to report.
H.R. 4981, to amend the Controlled Substances Act to improve access to opioid use disorder treatment.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at
Mr.
any
Chairman.
point. Are there amendments? Are there,
Mr. Chairman.
Dr. Bashan is recognized for 5 minutes.
Yeah. Mr. Chairman, H.R. 4981, the Opioid Use Disorder Treatment Expansion and Modernization Act, is the product of months of stakeholder engagement, expert input, and bipartisan negotiation. The opioid epidemic has left no area of this nation untouched. Every week we hear from our constituents and see it in the news, the direct impact this has on Americans' everyday lives. The evidence is clear that this epidemic is growing, and it will continue to grow unless immediate action is taken. As a doctor, a father, and a public policymaker, I want to do my part to help our communities overcome this challenge. That's why I'm proud to offer H.R. 4981, the Opioid Use Disorder Treatment Expansion and Modernization Act, today with my colleague from New York, Mr. Tonko. We've worked side by side over the past several months to find common ground and move forward with a good policy solution. Again, our final bill represents months of stakeholder engagement and bipartisan work to improve access and quality of treatment for opioid use disorder while limiting diversion. Our legislation increases access to opioid use disorder treatment where it is needed most by lifting prescribing caps in a responsible and measured manner, and provides a new class of capable practitioners in nurse practitioners and physician assistants the opportunity to train to become a waivered prescriber. It empowers physicians through education, training, and quality of care measures, allowing them to make informed decisions in the prescribing process for opioid use disorder treatment. It also encourages a multi-pronged approach to opioid use disorder treatment by providing physicians and patients education on a wider range of treatment options. And it deters bad actors both on the physician and patient side by implementing physician-crafted diversion control plans and giving HHS the tools to ensure physician compliance with best practices to rein in the abuse and over-prescription epidemic. Again, I want to thank my friend, Congressman Tonko, and all those who informed us throughout this process, and I look forward to H.R. 4981's passage here and on the House floor. I yield.
Gentleman yields back. Other members wishing to offer an amendment to the bill?
Yeah, I do have a bipartisan amendment, Mr. Chairman.
Gentleman has an amendment to the bill. The clerk will report the title.
Amendment to H.R. 4981, offered by Mr. Bouchon.
And the amendment will be considered as read. The staff will distribute the amendment, and the gentleman, who's your bipartisan sponsor? Dr. Bouchon?
No, I think I misspoke. It's a manager's amendment type.
Okay, it's just a Bouchon amendment.
Yep.
And the gentleman is recognized for 5 minutes in support of his amendment.
Yeah, thank you, Mr. Chairman. My amendment is technical in nature and clarifies the scope of the HHS report to Congress required in our bill. I urge my colleagues to support its adoption. I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Gentleman from New York, Mr. Tonko.
Thank you, Mr. Chair. In yesterday's markup proceedings, I thanked Representative Bouchon and his staff for the work and the staff of the committee to be able to bring this bill before us. And I think it's a strong bill. It's one that will be of great assistance. And this amendment is solely technical in nature, and ask that the committee members support it. And with that, I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Gentlelady from California, Ms. Capps.
Thank you, Mr. Chairman. I move to strike the last word. And in support of the Opioid Use Disorder Treatment Expansion Modernization Act, this bill represents months of work across the aisle to find effective solutions to help people with opioid addiction access the best treatments available. To combat opioid crisis, we need to support all avenues of prevention, treatment, and care, including access to medication-assisted treatment. But we know that far too many individuals who need and want help to curb their opioid addiction cannot access it. The bill before us recognizes this lack of capacity and would correct a long-standing omission that keeps certain providers, namely nurse practitioners and physician's assistants, from being a part of the solution. I'm pleased that this has already been referenced in our discussion. Nurse practitioners and physicians, PAs, physician's assistants, are the primary care providers for millions of Americans. They have extensive training and the ability to work meaningfully with patients affected by opioid abuse. And while their scope of practice, including prescribing abilities, are traditionally regulated at the state level, federal law needlessly prohibits them from prescribing Schedule 3, 4, or 5 drugs for treatment of opioid addiction, even when they can prescribe these drugs for other indications. This is detrimental to our fight against this opioid epidemic. In communities all across America, individuals are suffering because a shortage of providers exists who can treat them with buprenorphine. This bill before us would fix this discrepancy and allow these valuable healthcare providers to join the fight against opioid abuse in line with their current prescribing allowances determined by their state. Health professionals play a vital role in ensuring patient health and safety. With this bill, we would make meaningful progress by expanding the number of healthcare providers who are able to help those in need. I urge my colleagues to support this bill so we can continue the momentum in combating this crisis and expand access to care. We have to knock down artificial barriers such as the one this amendment addresses to care once and for all for everyone. I yield back.
Gentlelady yields back. Chair to recognize the gentleman from Pennsylvania, Dr. Murphy. 5 minutes.
Thank you, Mr. Chair. I'll just be brief. I wanted to strike the last word, but I want to comment on some wording added in the manager's amendment, which is extremely important. We know that when someone is on buprenorphine or the medication, I know a study was done in Pennsylvania and found that like 59% of patients did not have any counseling in the year that buprenorphine was prescribed. That's a concern because we know from our hearings we had here in the Oversight and Investigation Subcommittee, and as you mentioned before, Mr. Chairman, that very few people get any treatment. Only 10% have evidence-based care. It is extremely essential that if to make medication-assisted treatment work, to have other counseling that is done by someone who is a counselor dealing with drug and alcohol, because we want these people to not just have government-sponsored drugs, but to make sure that we are helping them on the road to recovery. So the language is going to require a report to Congress of access to the use of counseling and recovery support services, including the percentage of patients receiving such services, is extremely important in this bill, and I thank you, Mr. Chairman, for including that information in the bill. And with that, I yield back.
Gentleman yields back. Other members wishing to speak on the amendment offered by the gentleman from Indiana, Dr. Bouchon. Seeing none, the vote occurs on the amendment offered by Dr. Bouchon. All those in favor will say aye. Aye. Those opposed say no. Opinion of the chair, the ayes have it. The amendment is agreed to. Are there further amendments to the bill? Gentlelady from Colorado has an amendment at the desk.
Thank you.
Clerk will report the title.
What is the number of the amendment?
2. I think it's
It should be
2.
Amendment 2 on this bill.
Amendment to H.R. 4981 offered by Ms. Deget.
And the amendment will be considered as read. The staff will distribute the amendment, and the gentlelady from Colorado is recognized for 5 minutes in support of her amendment.
Thank you very much, Mr. Chairman. What this amendment does is it increases the cap on the number of patients physicians can treat at a given time with buprenorphine to 500. I want to thank Mr. Bouchon and Mr. Tonko for doing this bill. It's a very important bill. And as Mr. Murphy said, we had a number of hearings in the Oversight and Investigation Subcommittee last year on the subject of the opioid epidemic. What we heard was really sobering. Every day, 78 Americans die from an opioid-related overdose. And between 1999 and 2010, the death rate from prescription opioids more than quadrupled. And we also know that the epidemic is worsening. Just last year, the number of prescription opioid overdoses jumped another 9%, and overdoses due to heroin increased by 26%. But as we heard in our series of O&I hearings, The public health and treatment infrastructure hasn't kept pace with this expanding epidemic. We had federal, state, and local health officials and public health experts who told us of widespread and pervasive shortages in treatment capacity throughout the United States, in urban areas, in rural areas, everywhere. Only 1 in 10 individuals suffering from substance abuse receive any form of treatment, and only a fraction of those receive evidence-based treatments, including medicated assisted treatment, or MAT, such as BUP. Now, BUP has been proven both safe and effective in decreasing the number of fatal overdoses, increasing patients' retention in treatment, and reducing the risk of infectious disease transmission. Coupled with prenatal care in pregnant women who are addicted to opioids, it also reduces the risk of obstetrical, fetal, and neonatal complications. But despite strong evidence supporting the use of this as a public health intervention, access to BUP remains limited. There was one study that the University of Washington did which said that 53% of U.S. counties don't have a single physician who can prescribe this drug. The situation is particularly dire in rural counties where over 80% don't have a single waivered BUP prescriber. So when you expand access to BUP, it's going to be critical to addressing this crisis, and I support strongly this bill, which expands access by increasing the cap on the number of patients. But the problem is, when you only increase the cap of patients to 250, as this bill does, then you're not going to be able to get the kind of access to treatment that patients, particularly in rural areas, need. So I think that if you give addiction specialists and physicians who have taken extensive continuing medical education the ability to prescribe BUP, if you increase that up to 500 patients per physician, that will actually give patients the access that they need to this type of treatment. And as Mr. Murphy said, this type of treatment is a very skilled medical treatment that you need. And so not just every doctor can do it. They don't have that medical training to do it. These are providers with specialized knowledge and training to treat patients struggling with addiction. They can be trusted to exercise their professional judgment and manage their patient loads appropriately. I think probably we should remove the cap entirely. I don't know of any other situation where we have arbitrary limits on the number of patients that a provider can treat with a particular prescription drug. And in any other area of medicine, we wouldn't even consider proposals that amount to rationing of medical care, especially when there are so few trained professionals. But here's why I'm offering this amendment, is the Senate Health Committee has passed an amendment on a bipartisan basis that sets a 500 patient cap. And I think we could do that now very safely while protecting the integrity of this training and counseling that we're having, and also adding the new set of guardrails under H.R. 4981. I suspect that once we pass these bills through the House and the Senate with a cap of 500, we may want to go back at some point and revisit that. But in the meantime, 500 will vastly improve our ability to respond to this crisis on a widespread geographic basis. And so I would urge my colleagues to support this amendment. And I yield back.
Gentlelady yields back. Chair would recognize the gentleman from Indiana, Dr. Bashan.
Thank you, Mr. Chairman. This bill is a bipartisan agreement, board of good faith negotiations over a number of months and informed by experts and stakeholders in a transparent process. We had assistance from Department of Health and Human Services, and they noted proposals for higher caps than the 200 they proposed, specifically noting a cap of 500, and said they do not believe a provider could actually treat that number of patients while providing high-quality care. Given the data from HHS, which they clearly did their homework, and outside experts and other stakeholders, I believe that 250 patients is a reasonable compromise to ensure patients can find the care they need and the physicians can maintain quality practices. For these reasons, I urge my colleagues to vote no on this amendment, and I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none, The vote occurs on the amendment offered by the gentlelady from Colorado. Recorded vote has been asked for. The clerk will call the roll.
Mr. Barton. Mr. Whitfield. Mr. Shimkus. Mr. Pitts. Mr. Walden. Mr. Murphy. Mr. Burgess. Ms. Blackburn. Mr. Scalise. Mr. Latta. Mr. Latta. Mrs. McMorris Rogers. Mr. Harper. Mr. Lance. Mr. Guthrie. Mr. Olson. Mr. McKinley. Mr. Pompeo. Mr. Kinzinger. Mr. Griffith. Mr. Bilirakis. Mr. Johnson. Mr. Long. Mr. Bouchon. Mr. Flores. Ms. Brooks. Mr. Mullen. Mr. Hudson. Mr. Collins. Mr. Kramer. Oh, Ms. Elmers. Mr. Pallone. Mr. Pallone votes aye. Mr. Rush. Mr. Rush votes aye. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Engel. Mr. Engel votes aye. Mr. Green. Mr. Green votes aye. Ms. DeGette. Ms. DeGette votes aye. Ms. Capps. Ms. Capps votes aye. Mr. Doyle. Ms. Schakowsky. Ms. Schakowsky votes aye. Mr. Butterfield. Mr. Butterfield votes aye. Ms. Matsui. Ms. Matsui votes aye. Ms. Castor. Ms. Castor votes aye. Mr. Sarbanes. Mr. Sarbane votes aye. Mr. McNerney. Mr. McNerney votes aye. Mr. Welch. Mr. Welch votes aye. Mr. Lujan. Mr. Lujan votes aye. Mr. Tonko. Mr. Tonko votes aye. Mr. Yarmouth. Mr. Yarmouth votes aye. Ms. Clark. Ms. Clark votes aye. Mr. Loebsack. Mr. Schrader. Mr. Schrader votes aye. Mr. Kennedy. Mr. Kennedy votes aye. Mr. Cardenas. Mr. Cardenas votes aye. Chairman Upton.
Votes no.
Chairman Upton.
Other
votes-
members wishing to cast a vote. Mr. Shimkus.
Mr. Shimkus votes no.
Mr. Olson.
Mr. Olson votes no.
Other members. Mr. Kramer.
Mr. Kramer votes no.
The members wishing to cast a vote? Seeing none, clerk will report the tally.
Mr. Chairman, on that vote, there were 17 ayes and 29 noes.
Is that right? Can you just check that count again? Is that right? It's not just.
Mr. Chairman, on that vote, there were 21 ayes and 25 noes.
21 ayes, 25 noes. The amendment is not agreed to. Are there further amendments to the bill? The gentleman from New Jersey. Has
I
amendment at
do.
the desk?
Yeah, I think there's only one.
Clerk will report.
Oh, one.
Clerk will report that title of the amendment 01? The gentleman was not recorded, but the vote has been closed. Sorry. We've called up the next amendment already. Clerk will report the title of the amendment.
Amendment to H.R. 4981, offered by Mr. Pallone.
And the amendment will be considered as read. The gentleman from staff will distribute the amendment. The gentleman from New Jersey is recognized for 5 minutes in support of his amendment.
Mr. Chairman, I'd like to offer an amendment. It's simple. It would increase the cap on the number of patients physicians can treat at a given time with BUP to 300. As I've stated before, I find the existence of a cap on the number of patients a provider can treat with a particular medication to be totally nonsensical. In every other area of medicine, we trust healthcare providers to manage their patient load responsibly. In this instance, we're not trusting doctors who are on the front lines of this crisis to use their professional judgment in order to provide treatment for individuals facing the battle of their lives with opioid addiction. The Data 2000 framework is outdated, unscientific, and seems to be rooted in stigma and prejudice against people with substance abuse disorders rather than scientific evidence. Proposals to ration the amount of prescription drugs a provider can dispense for any other medical condition would be uniformly met with consternation from members on both sides of the aisle. But we treat addiction differently because society continues to view it as a moral failing or a flaw of character rather than as a medical condition and a chronic disease. So I think it's time for our attitudes and for this outdated statutory regime to catch up with the science. As a result of this misguided policy, patients suffering from heroin and opioid abuse face a critical lack of access to evidence-based treatments, particularly BUP. As I mentioned during the subcommittee markup, Dr. Waller provided written testimony on the TREAT Act that with regards to treatment with BUP, over half of physicians surveyed by the American Society of Addiction Medicine held wait lists of over 100 patients. Personally, I find the existence of wait lists for patients in crisis to be unconscionable. Every day a patient is left waiting for treatment is another day that patient remains at risk for a potentially fatal overdose. I think it's important to note that in addition to the clear detriment to public health, these wait lists create ripple effects on our criminal justice system. During our discussions of the regulations surrounding BUP and the Data 2000 framework, many have tried to weigh the risks of Medicaid diversion. While this is an important concern, I'm worried that we're viewing diversion through the wrong lens. A recent study by the Journal of American Medicine noted that, and I quote, attempting but failing to enter an outpatient BUP treatment program has been identified as a risk factor for use of diverted BUP. We should not be surprised when the authors found that over 3/4 of the users of diverted BUP were for individuals attempting to self-treat symptoms of withdrawal or addiction. The researchers' conclusion was striking, and I quote, the high percentage of use of diverted medication for self-treatment may be a sentinel public health signal that treatment needs are not being met and that improved access to and or expansion of treatment are essential. Although diversion of BUP is certainly a legitimate concern, this suggests that much of this problem is one of our own creation. Because of an inflexible, arbitrary cap on treatment, wait-listed patients are actually turning to their drug dealers for BUP treatment rather than to their doctors. And we have the power to change this. Our nation's addiction specialists and healthcare providers are in agreement that the BUP cap should be raised significantly. Increasing the cap would increase both the access to care for patients as well as the quality of care that patients receive. So I strongly urge my colleagues to vote in favor of this amendment. Again, you know, the Senate, I don't even think we should have any cap. The Senate and Ms. DeGette suggested the 500. Mine is 300, which is only 50 more than the 250. So I'd like to see it as a sort of compromise, a little above the compromise that's in the legislation. And I yield back.
Gentleman yields back. Chair to recognize gentleman from Indiana, Dr. Bouchon.
Thank you, Mr. Chairman. Again, this bill is a bipartisan agreement born of good faith negotiations over a number of months and informed by experts and stakeholders in a transparent process. The administration, Health and Human Services, landed at a number of 200, doubling the current number. We saw at subcommittee an amendment to move caps to 200 and one to move them to 300. And as part of our good faith effort to reach a compromise, we went further than Health and Human Services to 250. But the Secretary maintains the authority to change that cap however she sees fit. Given the data from Health and Human Services, as I mentioned, clearly did their homework, outside experts and other stakeholders, 250 is a reasonable compromise to ensure patients can find the care they need and physicians aren't undertaking too large of a patient population, compromising the quality of medical care. For these reasons, I urge my colleagues to vote no on this amendment, and I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Gentleman from New York, Mr. Tonko.
Thank you, Mr. Chair. I move to strike the last word. Thank you, Mr. Chair. I rise in support of the amendment. At the outset, let me say that I respect the diversity of opinions on this issue. Dealing with the patient cap number is one of the most vexing problems that we had to deal with in crafting this bill. There simply isn't a whole lot of data or rationale for why a 250 patient limit is better than 200 or 300 or 500 for that matter. A lot of the frustration on both sides stems from the fact that no matter where you land, you are still imposing some sort of arbitrary limit. No matter where you land, someone struggling with addiction will be denied treatment because of an obscure government rule. In other areas of medicine, federal government mandated patient limits would not be tolerated. We don't put a cap on the number of patients with mental illness a psychiatrist can treat, even though these individuals are going to require the same level of care and attention and wraparound services that those grappling with addiction will need. We don't put limits on the number of pain patients a pain specialist can see, even though some of the bad actors in this space are the same that are helping to drive this opioid crisis. In each of these cases, we trust the doctors to do their job and provide appropriate care to their patients. So what it really comes down to is that fact that we still have an enduring stigma surrounding addiction medicine, that somehow these doctors and these patients are not to be treated as part of our medical system. They shouldn't be trusted and instead should be watched with a wary eye from the federal government. If diversion is the main concern, we should also be putting patient limits on the most commonly diverted drugs, which are the opioids themselves. At some point, if we are going to talk the talk about treating addiction like a public health crisis, I believe we also need to walk the walk. That being said, I understand the political realities of the situation, and I do believe that lifting the cap even to 250 will do immense good, especially when you factor in expanding prescribing privileges to nurse practitioners and to physician assistants. We worked in good faith to arrive at the 250 number, and it's certainly better than what we have now, and I will respect the committee's decision-making on this issue. However, at the end of the day, 250 is still an arbitrary number. As we vote on this amendment, I would urge my colleagues on both sides of the aisle to ask themselves this simple question. If we're going to err when assigning these arbitrary numbers, isn't it better to err on the side of opening up treatment to more individuals, to do all we can to ensure people aren't dying while waiting weeks, if not months, for treatment? If you agree, I would urge you to support this very modest amendment. And with that, I thank you, Mr. Chair, and yield back the balance of my time.
Gentleman yields back. Other members wishing to speak on the amendment? Gentleman from Pennsylvania.
Thank you, Mr. Chairman. Actually, myself, I'm feeling that even going up to 250, I think is too high right now. And I know that members are deeply concerned about this issue. So it comes down to this. When I have gone to some of these clinics in my district and others and have talked to the prescribers to try and get some sense of how much time they're actually spending with these patients struggling with this major disease, it's actually very limited. And when we have had hearings here in our oversight committees and health committees, subcommittees, and have asked how much time do the doctors actually spend with patients, they didn't know. When I have asked some, they said perhaps a couple minutes. Now, of course, if you're only seeing someone for a couple minutes, you can crank through quite a few every day. But let's keep a couple things in mind. That the key is to get people into recovery. And that means not just writing prescriptions, but making sure they're getting other treatment. As Mr. Getz talked about, how you have to have people very qualified doing this work. This is not simple work to help someone. We also know when someone has an addiction disorder, they get their family members to be enablers and codependent on them. They game the system. Sadly, when you're dealing with a serious addiction, these are folks who would sell their children, literally, who bankrupt their families, who lie in many cases just to maintain their addiction. They divert their medication, buprenorphine, the third most diverted drug. When you have a clinic that does this right and a doctor does it right, they will randomly call their patients and say, stop at a pharmacist now. We want a pharmacist to do a pill count. How many are left? Is it too few? Did you sell those off? They'll make sure they do urine drug screens on a regular basis. Do they have the proper levels of buprenorphine? Did they suddenly take one just before they came in so it shows? Or do they have proper levels? Do they have mixture of other opiates in there as well? This takes a lot of time to do this right. And I understand the issue the ranking member has in there. And I think this is where we want to make sure we have more providers doing this and more trained professionals in the area of addiction and drug abuse, so we're helping people deal with this terrible epidemic in America, which is so deadly. But I think raising it more, I have concerns even getting it to 250. I'm willing to accept that for now, provided we do these other studies. And in the future, I think as we get more providers, as we get people to spend more time with patients, we can make more progress on this deadly disease. And with that, I yield back.
Chairman yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by the gentleman from New York. Roll call has been requested. The clerk will call the roll.
Mr. Barton. Mr. Whitfield. Mr. Whitfield votes no. Mr. Shimkus. Mr. Shimkus votes no. Mr. Pitts. Mr. Pitts votes no. Mr. Walden. Mr. Walden votes no. Mr. Murphy. Mr. Murphy votes no. Mr. Burgess. Mrs. Blackburn. Mrs. Blackburn votes no. Mr. Scalise. Mr. Latta. Mr. Latta votes no. Mrs. McMorris Rogers. Mr. Harper. Mr. Lance. Mr. Lance votes no. Mr. Guthrie. Mr. Guthrie votes no. Mr. Olson. Mr. Olson votes no. Mr. McKinley. Mr. McKinley votes no. Mr. Pompeo. Mr. Kinzinger. Mr. Kinzinger votes no. Mr. Griffith. Mr. Bilirakis. Mr. Bilirakis votes no. Mr. Johnson. Mr. Johnson votes no. Mr. Long. Mr. Long votes no. Mrs. Elmers. Mrs. Elmers votes no. Mr. Bouchon. Mr. Bouchon votes no. Mr. Flores. Mr. Flores votes no. Mrs. Brooks. Mr. Mullen. Mr. Mullen votes no. Mr. Hudson. Mr. Collins. Mr. Kramer. Mr. Pallone. Mr. Pallone votes aye. Mr. Rush. Mr. Rush votes aye. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Engel. Mr. Engel votes aye. Mr. Green. Mr. Green votes aye. Ms. DeGette. Ms. DeGette votes aye. Ms. Capps. Ms. Capps votes aye. Mr. Doyle. Ms. Schakowsky. Ms. Schakowsky votes aye. Mr. Butterfield. Mr. Butterfield votes aye. Ms. Matsui. Ms. Matsui votes aye. Ms. Castor. Ms. Castor votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. McNerney. Mr. McNerney votes aye. Mr. Welch. Mr. Welch votes aye. Mr. Lujan. Mr. Lujan votes aye. Mr. Tonko. Mr. Tonko votes aye. Mr. Yarmouth. Mr. Yarmouth votes aye. Ms. Clark. Ms. Clark votes aye. Mr. Loebsack. Mr. Loebsack votes aye. Mr. Schrader. Mr. Schrader votes aye. Mr. Kennedy. Mr. Kennedy votes aye. Mr. Cardenas. Chairman Upton.
Votes no.
Chairman Upton votes no.
Other members wishing to vote? Mr. Cardenas.
Mr. Cardenas votes aye.
Mr. Griffith.
Mr. Griffith votes no.
Mr. Pompeo.
Mr. Pompeo votes no.
Mr. Harper.
Mr. Harper votes no. Mr. Burgess?
Mr. Burgess. Dr. Burgess.
Dr. Burgess votes no.
Other members wishing to cast a vote? Seeing none, the clerk will report the tally.
Mr. Chairman, on that vote, there are 22 ayes and 24 noes.
22 ayes, 24 noes. The amendment is not agreed to. Are there other amendments to the bill? Gentlelady from New York.
Thank you, Mr. Chairman. I have an amendment at the desk.
Clerk will report the title.
Amendment to H.R. 4981 offered by Ms. Clark.
The amendment will be considered as read. The staff will distribute the amendment, and the gentlelady from New York is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Speaker, Mr. Chairman. I'd like to offer an amendment which would provide for additional educational requirements for healthcare providers who the Secretary identifies as overprescribing opioid pain medications. I'd like to make clear that I believe and I support mandatory continuing medical education for all practitioners who prescribe opioid medications. In fact, I've introduced a bill, H.R. 3889, the Safer Prescribing of Controlled Substances Act, to do just that. My bill would require all practitioners to take continuing medical education as part of the granting or renewal of the DEA license to prescribe controlled substances. I continue to believe that this is a critical component to addressing the opioid crisis, since most public health experts agree that the current crisis is being driven by the overprescribing of prescription pain medication. I understand that my bill faces opposition from some provider groups who oppose mandated continuing medical education at the federal level. Today, I'm offering a narrower amendment, one that I hope represents a balanced approach that members on both sides of the aisle can support. One of the difficulties in addressing the opioid epidemic is ensuring a proper balance between the appropriate treatment of pain and the risk of an excessive supply of opioids in our communities. In the face of this, we know there's tremendous variation between doctors that practice in the same field or even in the same hospital or office. According to the CDC, in all states surveyed, the top 10% of prescribers wrote half or more of the opioid prescriptions in their states. This is not limited to any one specialty. In a survey of family physicians, 41% felt a colleague in their own practice overprescribed opioids for chronic non-cancer pain. Given that historically very few medical schools offer training in pain management and even fewer offer any coursework in addiction, we should not be surprised that the New England Journal of Medicine recently found that many doctors do not feel confident in how to prescribe opioids safely. This amendment will ensure that high-volume prescribers are armed with the additional training on the best practices of pain management, tools to manage adherence and diversion of opioids, as well as tools to detect patients with signs of addiction and link them to treatment. It is important to note that this amendment is flexible and designed to be specialty specific. Family doctors will be compared to other family doctors, orthopedic surgeons to orthopedic surgeons, and so on. This amendment will have several effects. First, it will raise awareness among prescribers on the current norms of opioid prescribing. Second, it will increase patient safety. If a prescriber begins to prescribe opioids in volumes that are well outside the norms of their practice or specialty, it is common sense that they will be provided with additional training to ensure that they are up to date on current practice standards and are prescribing safely. I thank you, and I urge you to pass this very important amendment.
Gentlelady yields back. Chair would recognize anybody? Mr. Pitts. Dr. Bouchon.
Yep. Thank you, Mr. Chairman. Within the scope of the dialogue on this bill today between myself and Mr. Tonko over the past several months, this issue has not come up. Our bill is focused on prescribing medication for substance abuse disorder. We've been in discussion on this bill for months, and we've continued those discussions on amendments since the subcommittee markup. This amendment was not part of those discussions. Given we're just seeing this amendment this morning and it is outside the scope of an already complicated bill, I urge my colleagues to oppose this amendment. I yield back.
Chair would recognize the gentleman from New Jersey, Mr. Pallone.
I move to strike the last word. I'd like to speak in favor of this important amendment that would require provider education for physicians who prescribe opioid pain medication in volumes exceeding the norms of their field. In 2014, pharmacies in the U.S. dispensed approximately 245 million prescriptions for opioids. This is enough to provide a script to every adult in our entire nation. At the same time, we know that over 5 million Americans use prescription pain relievers either recreationally or to satisfy an opioid addiction. This combination has produced tragic results. 2014 produced the highest number of drug overdose deaths than any previous year on record, with opioids and heroin driving the recent surge. Unfortunately, our nation's doctors and healthcare providers have not been provided the tools and education necessary to safely prescribe these medications in the midst of an opioid epidemic. Recently, an article in New England Journal of Medicine examined this topic and found, I quote, that very few medical schools offer adequate training in pain management, and still fewer offer even one course in addiction. The consequences are unsurprising. The same authors discovered that, and I quote, many physicians admit that they are not confident about how to prescribe opioids safely, how to detect abuse or emerging addiction, or even how to discuss these issues with patients. And as a result, we've created a patchwork of prescribing practices with tremendous variation, both geographically as well as even within the same field. So the Clark Amendment would ensure that providers who disproportionately prescribe opioids compared to their peers receive the additional education and training to match the needs of their clinical practice. This education will ensure that providers are equipped to prescribe pain medications in the safest manner available, recognize signs of abuse, and are equipped with the best available knowledge to care for patients who are struggling with addiction. I believe this thoughtful approach will target the highest priority prescribers and avoids a rigid solution that may interfere with appropriate pain management. And I would urge my colleagues to support this important amendment. It's basically a common sense step that will assist doctors in their ability to provide high quality pain management while at the same time minimizing the risk of misuse and addiction. I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none. Does the gentlelady withdraw her amendment?
I do, Mr.
Ask
Chairman.
unanimous consent to withdraw.
I do.
The amendment is withdrawn. Other amendments to the bill?
Mr. Chairman, I have an amendment to that.
Gentleman from New Mexico is recognized. The clerk will report the title of the bill.
Amendment to H.R. 4981, offered by Mr. Lujan.
And the amendment will be considered as read, and the staff will distribute the amendment. The gentleman is recognized for 5 minutes in support of his amendment.
Mr. Chairman, my home state of New Mexico has been especially hard hit by the drug crisis. The drug overdose rate in New Mexico is at 27.3 per 100,000. This is the second highest in the country and roughly double the national average. In 2 counties in my home district, the overdose rate is more than 4 times the national average. In 2014, drug overdoses claimed the lives of 547 New Mexicans. 547 lives. 547 people who missed Thanksgiving dinner or their child's softball game. 547 people who weren't able to help their kids with their math homework or kiss their spouse goodnight. 547 brothers, sisters, parents, and friends that we lost too soon. And while the crisis has hit New Mexico hard, this crisis touches everyone, whether they live in rural communities, the suburbs, or the inner city. According to the American Society of Addiction Medicine, drug overdose is the leading cause of accidental death in the United States, with 47,055 lethal drug overdoses in 2014. 47,055 legal drug overdoses. Each member of this committee represents someone who suffered this tragedy or lost someone that they love. These are our constituents, our friends, and our loved ones. This is why the work we're doing today is so important, and I thank the chairman, the ranking member, the authors of the legislation, and my colleagues for their efforts to address this crisis. But I think it's abundantly clear that we have to do more. That's why I'm offering an amendment that reflects the President's proposal for new and expanded funding of $1 billion to combat the drug crisis plaguing our country. This funding will provide needed support to states to help them expand treatment capacity and make services more affordable and available. But this only represents a down payment to address this crisis. Though no single solution will solve this crisis, one thing is clear. Right now, there just are not enough resources to go around, and I urge adoption of this amendment. With that, Mr. Chairman, I yield back the balance of my time.
Gentleman yields back. Other members wishing to speak? Gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman. I urge my colleagues to oppose this amendment as it is fiscally irresponsible and represents bad process. The amendment would add $1 billion with a B dollars in new authorizations over 2 years. This amendment was filed at the last minute without detailed discussions between the majority and minority. And while we believe targeted new authorizations make sense, the committee should not adopt last-minute hurried amendments that create a new $1 billion authorization. After a lot of bipartisan work and discussion, the committee is working together to find new authorizations for residential treatment programs, co-prescribing, and promoting the availability of naloxone. I believe we will successfully reach bipartisan agreement on those new authorizations during our markup and pay for those new authorizations, and that agreement will be reached after discussion and give and take from the majority and minority. That is the way to achieve bipartisan consensus, to get targeted resources to programs to fight the opioid epidemic while being fiscally responsible. So I urge my colleagues to oppose the amendment, and I yield back.
Gentleman yields back. Chair recognizes the gentleman from New Jersey.
Thank you, Mr. Chairman. I want to speak in favor of the amendment. We're here today because we're in the midst of an unprecedented opioid and heroin crisis. Sadly, 2014 saw the highest number of drug overdose deaths than any other year on record. Our public health and treatment systems have not kept pace with the expanding epidemic. Over this committee's hearings on the opioid epidemic, we've learned of the significant shortage of substance abuse providers nationwide. Those struggling with heroin or opioid addiction suffer from critical shortages in treatment access. Only 1 in 10 individuals suffering from substance abuse disorders receive any form of treatment. Medication-assisted treatment is an evidence-based strategy that helps patients recover from addiction and reduces the risk of overdose. Yet only 9% of all substance abuse treatment facilities nationwide offer medication-assisted treatment. And this issue is directly tied to our workforce. One study showed that 74% of substance abuse treatment organizations found it either somewhat difficult or very difficult to find physicians in the local community with experience in treating individuals with substance abuse disorders. Now, given the tremendous gap between the supply and demand for substance abuse treatment, it's a farce to believe that we can mount a forceful response to this epidemic without providing additional resources. And that's why I support the amendment to provide $1 billion in mandatory funding to modernize our treatment systems and provide critical tools to attack the opioid epidemic head-on. This proposal tracks the President's mandatory funding request released earlier this year. Most of this money would go directly to the states to enable them to increase treatment capacity through cooperative agreements to expand access to medication-assisted treatment for opioid use disorders. And this proposal provides for a targeted response where funding is allocated to the areas hit the hardest by the epidemic. It's going to empower states to adopt innovative solutions to increase treatment capacity, as well as make treatment more affordable. Now, we also know that rural areas face added difficulties. Rural areas have been hit hardest by the epidemic, and patients in these rural areas face heightened barriers to accessing care. This amendment provides funding for physicians with training in opioid use disorders to participate in the National Health Service Corps. This important program brings healthcare providers to underserved areas to address critical gaps in care. And finally, as we modernize our treatment system, we need to learn what strategies are most effective. That's why this amendment provides funding to evaluate the effectiveness of different treatment programs in reducing opioid use disorders, overdose, and death. I'd urge my colleagues to vote in favor of the amendment. Let's not make any mistake about it. If we don't bring resources to the table in our fight against this epidemic, we're going to fail. Anything less than a robust response to address this crisis will result in increased deaths and place tremendous emotional and financial burdens upon our families. And if we do as my Republican colleagues propose and wait until that normal appropriation cycle to provide more funding, we'll be essentially turning a blind eye to the deaths and devastation this crisis is causing to individuals, families, and communities each day. We still have about 5 months left in the fiscal year. That means at the current rate of 78 lives lost each day to opioid overdoses, almost 12,000 more people will have died from opioid epidemic while we waited around. And these are just the deaths. There's thousands more that will be left to battle the disease without treatment and recovery support, because in the richest country in the world, we decided that fiscal austerity trumps saving lives and protecting the public health. And I just find this unacceptable. And finally, if Congress doesn't take a proactive approach in providing the necessary resources, we'll also pay for the collateral consequences of this epidemic through our emergency departments and the criminal justice system, meaning that we save money today at the expense of lives lost and increased spending. So I think it's time for Congress to step up and provide states and communities and families with the tools that they need. And therefore, I would urge my colleagues to support this amendment. Did the gentlewoman, I'll yield to the gentlewoman.
I agree with the gentleman, and I thank him for yielding just a moment to me. You know, we are an authorizing committee, and our work is always done in that frame. But I think, to a member that has spoken on this whole issue of opioids, and we've heard the stories from members and how their congressional district and rural areas, urban, suburban, how this is a real epidemic that is taking a toll on our country. If there are not dollars attached to this to do something about it, I know that $1 billion is something that none of us have in our checking account, but we do have 50 states. So anytime there's an amount that comes up, divide it by 50 and see what will be coming to your state. I'm from California. We're a nation state. Would $200 million take care of the issue in California? I doubt it. Do I think it would put a dent in it? Yes, I do. So when you hear these numbers and just reject them out of hand, divide it by 50, and then think of how those dollars would apply to your constituents, to the stories that you're telling. I think that you know, if people want to go out and brag that the committee did something on this, then it's language. It's just words. You have to put resources, we have to put resources in this to actually meet the challenge that is legitimately called an epidemic. And I yield back. Thank you.
Gentleman's time has expired. Gentleman from Illinois. Gentleman's recognized for 5.
Mr. Chairman, first of all, I want to applaud the committee, you and the ranking member, for really paying some attention to this critical problem that we are confronted with as a nation. This problem in terms of addiction. And I think we can go much further than we've gone. I think that some of the amendments that have been forwarded for the consideration of this committee are in need of service, great service to our nation, and should have passed and should pass. Other amendments should pass that are being brought up. Mr. Chairman, I just want to say that it is the issue of addictions, be it opiate or heroin, other kinds of addictions. This is an issue that I hope and I pray that this committee will really take under serious consideration in the immediate future. Mr. Chairman, this committee, this Congress, federal government failed miserably when the issue of crack cocaine was at the forefront of addictions in districts like mine throughout the nation. Please and pleadings, the pain and suffering of so many Americans were completely ignored by this Congress, by past Congresses, and by the federal government in particular. As a result, you had we had just the opposite emphasis when this nation was confronted by the epidemic of crack cocaine. Rather than using this as and viewing this as a medical issue, as an issue of public health, it was viewed as an issue of criminal justice, left to the law enforcement agencies throughout America to address this issue of crack cocaine. And what we've seen as a result of that is the mass incarceration of minorities, blacks, African Americans, Latino Americans, and the resultant explosion of the cost of keeping these individuals in prisons to the federal budget. And we've also seen the destruction of families throughout the nation, particularly in districts like mine. So there are some families in my district who have and are dealing with issues of opiate addictions, but they aren't at the level that they are in terms of dealing with the issue of crack cocaine. And I just want to remind members of this committee that you have to look beyond that which is familiar to you. And if Americans are suffering, no matter what quarter, what community, no matter what race, creed, or religion that they may respond to, they may express, we have an underlying responsibility to deal with addictions that are ripping the basic social fabric of our nation apart. We have a responsibility to deal with all the addictions, not just this addiction that affects families who are familiar to us and who have similar preoccupations that we do. Mr. Chairman, I just want to say, let's deal with the addiction. Let's deal with heroin addiction and not just play around the edges of it. Let's really take this issue up and deal with this addiction as well as other addiction, not just opiate addictions. Thank you. I yield back.
Gentleman yields back. Other members wishing to speak on the amendment. Gentlelady from Illinois.
Thank you, Mr. Chairman. I'll be brief. I'm proud to support Congressman Lujan's amendment. You know, there's so much we agree on today, that we have an opioid abuse epidemic, that every single day 78 people die from opioid overdoses, that there's not a community that hasn't been impacted by this horrible crisis, and yet my Republican colleagues continue to oppose meaningful investments to expand access to treatment. And this comes on top of years of insufficient funding for our existing substance abuse programs. Just one example, the Substance Abuse Prevention and Treatment Block Grant within SAMHSA, and that, of course, is the primary federal program that funds substance abuse prevention and treatment programs, has actually been cut in real dollars by 25% in the last 10 years. So Congressman Lujan's amendment will help to end the cycle of underinvesting by providing $1 billion in mandatory funding to expand access to treatment, expand our behavioral health workforce, and evaluate treatment methods. And I think we can all agree that this is a worthy investment. We all have those horrific stories of families who've lost loved ones to the disease of addiction. We have also heard the stories of people who are ready to seek treatment and can't access it due to both the cost and the lack of availability of treatment. So I strongly support this amendment, urge my colleagues to vote for it, and yield the balance of my time to Mr. Lujan.
Thank you, Ms. Schakowsky. And Mr. Chairman, You know, as we look at this as well and look at the numbers that are included in the amendment, these are not pie in the sky numbers. These are numbers that were looked at not only by SAMHSA, by HRSA for the National Health Service Corporation, looking at state targeted response cooperative agreements, studies, to see the maximum way that we can make sure we're looking after the constituents that we all represent. And what concerns me is, as we look at the notion that providing an investment this size to help our constituents with the overdose problem that is a health crisis facing America, I don't understand. Some of the same words have been used when we are having debates about providing support for the millions of people in Puerto Rico, to offer them support, that it's fiscally irresponsible to help the people of Puerto Rico where septic systems in schools are overflowing because they have to, the leadership of Puerto Rico has to make a decision as to where they're going to put their resources. But it's fiscally irresponsible to go and help the people of Puerto Rico. The Zika dilemma that is facing and crushing lives as we speak, taking lives, that it's fiscally irresponsible to go and help the victims of Zika and to help stop this from happening. And Flint, Michigan, that it's fiscally irresponsible to go and help the people of Flint with the recommendations that have come forward. And now we're hearing the same thing with the opioid crisis facing the country. If we're looking for a pay for, maybe we should look to the lives that have been lost, that have paid for this. And so I hope that we take a minute to understand this, that when we describe these programs and the importance of these investments, then maybe we find a different way to describe them. With that, Mr. Chairman, I yield back the balance of my time. I still hope that we might be able to get some support here, or find a way to work on this as we get to the floor as well. And I yield back to Ms. Chakowski.
Gentlelady yields back. Other members wishing to speak on the amendment? Seeing none, vote occurs on the amendment. Recorded vote has been asked. The clerk will call the roll.
Mr. Barton? No. Mr. Barton votes no. Mr. Whitfield? Mr. Whitfield votes no. Mr. Shimkus? Mr. Shimkus votes no. Mr. Pitts? Mr. Pitts votes no. Mr. Walden? Mr. Walden votes no. Mr. Murphy? Mr. Murphy votes no. Mr. Burgess? Mr. Burgess votes no. Mrs. Blackburn? Mrs. Blackburn votes no. Mr. Scalise? Mr. Latta? Mr. Latta votes no. Mrs. McMorris Rogers? Mr. Harper? Mr. Harper votes no. Mr. Lance? Mr. Lance votes no. Mr. Guthrie? Mr. Guthrie votes no. Mr. Olson? Mr. Olson votes no. Mr. McKinley? Mr. McKinley votes no. Mr. Pompeo? Mr. Pompeo votes no. Mr. Kinzinger? Mr. Kinzinger votes no. Mr. Griffith? Mr. Griffith votes no. Mr. Bilirakis? Mr. Bilirakis votes no. Mr. Johnson? Mr. Johnson votes no. Mr. Long? Mr. Long votes no. Mrs. Elmers? Mr. Bouchon? Mr. Bouchon votes no. Mr. Flores? Mr. Flores votes no. Mrs. Brooks? Mr. Mullen? Mr. Mullen votes no. Mr. Hudson? Mr. Collins? Mr. Kramer? Mr. Pallone? Mr. Pallone votes aye. Mr. Rush? Mr. Rush votes aye. Ms. Eshoo? Ms. Eshoo votes aye. Mr. Engel? Mr. Engel votes aye. Mr. Green? Mr. Green votes aye. Ms. DeGette? Ms. DeGette votes aye. Ms. Capps? Ms. Capps votes aye. Mr. Doyle? Ms. Schakowsky? Ms. Schakowsky votes aye. Mr. Butterfield? Mr. Butterfield votes aye. Ms. Matsui? Ms. Matsui votes aye. Ms. Castor? Ms. Castor votes aye. Mr. Sarbanes? Mr. Sarbanes votes aye. Mr. McNerney? Mr. McNerney votes aye. Mr. Welch? Mr. Welch votes aye. Mr. Lujan? Mr. Lujan votes aye. Mr. Tonko? Mr. Tonko votes aye. Mr. Yarmouth? Mr. Yarmouth votes aye. Ms. Clark? Ms. Clark votes aye. Mr. Loebsack? Mr. Loebsack votes aye. Mr. Schrader? Mr. Schrader votes aye. Mr. Kennedy? Mr. Kennedy votes aye. Mr. Cardenas? Chairman Upton.
Votes no.
Chairman Upton.
Other members wishing to cast a vote? Seeing none, clerk will report the tally. Oh, Mr. Cardenas.
Mr. Cardenas votes aye. Mr. Chairman, on that vote, there were 22 ayes and 24 noes.
22 ayes, 24 noes. The amendment is not agreed to. Are there further amendments to the bill? Seeing none, the vote question now occurs on favorably reporting H.R. 4981 as amended to the House. All those in favor shall signify by saying aye. Aye. Those opposed say no. Ayes appear to have it, and the bill is favorably reported. The chair now calls up H.R. 4969 as amended by the Subcommittee on Health and asks the clerk to report.
H.R. 4969. To amend the Public Health Service Act to direct the Centers of Disease Control and Prevention to provide for informational materials to educate and prevent addiction in teenagers and adolescents who are injured playing youth sports and subsequently are prescribed opioids.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. Are there any bipartisan amendments to the bill? Gentleman from Pennsylvania, Mr. Pitts.
Pitts 01. Mr. Chairman, I have an amendment at the desk.
The clerk will report the title of the amendment.
Amendment to H.R. 4969 offered by Mr. Pitts.
And without objection, the reading of the amendment is dispensed with, and the staff will distribute the amendment. The gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to offer a bipartisan amendment that simply makes technical changes to H.R. 4969, the John Thomas Decker Act. H.R. 4969 directs the Secretary of HHS to provide informational materials to educate and prevent opioid addiction in teenagers and adolescents who are prescribed opioids due to a sports injury. One study found that adolescents and teenagers who played a high-injury competitive sport and were prescribed an opioid had a 50% higher chance of non-medical use of prescription opioids than their peers who did not participate in these types of sports. So I urge my colleagues to support the amendment and the underlying legislation. Yield back.
Gentleman yields back. Are there other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by Mr. Pitts. All those in favor will say aye. Aye. Those opposed say no. Can you chair? The ayes have it. The amendment is agreed to. Further amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 4969 as amended to the House. All those in favor shall signify by saying aye. Aye. All those opposed say no. In the opinion of the chair, the ayes have it, and the bill is favorably reported. Chair now calls up H.R. 4599 as amended by the Subcommittee on Health and asks the clerk to report.
H.R. 4599, to amend the Controlled Substances Act to permit certain partial fillings of prescriptions.
Without objection, the reading of the bill is dispensed with. Are there amendments to the bill?
Mr. Chairman.
Gentleman from Massachusetts, Mr. Kennedy. As an amendment at the desk, or strike the last word?
An amendment at the desk, please.
Clerk will report the title of the amendment.
Amendment to H.R. 4599 offered by Mr. Kennedy.
And the amendment will be considered as read, and the staff will distribute the amendment, and the gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, this amendment would make a small technical correction to clarify the bill's language on partial fill prescriptions. Specifically, it removes some unnecessary language while preserving the bill's goal of reducing the number of unused Schedule II drugs that are at high risk of diversion. I was proud to support this legislation offered by my Massachusetts colleague, Catherine Clark, at the subcommittee markup last week, and I believe this clarifying amendment will only make the bill stronger. By passing this bipartisan, bicameral bill, we can give providers and patients the ability to reduce the amount of unused opioids that remain in their medicine cabinets within reach of those battling substance use disorder. Thank you, Mr. Chairman. I yield back.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by the gentleman from Massachusetts. All those in favor say aye. Aye. Those opposed say no. Opinion share. The ayes have it. The amendment is agreed to. Further amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 4599 as amended to the House. All those in favor will signify by saying aye. Aye. Those opposed say no. The ayes appear to have it. The ayes have it, and the amendment, the bill, is favorably reported. Chair now will call up 4976. By the way, we're going to do, this is the last of 3 bills. Then we'll stop. 2 more after this. So the chair will ask the clerk to report.
H.R. 4976, to require the Commissioner of Food and Drugs to seek recommendations from an advisory committee of the Food and Drug Administration before approval of certain new drugs that are opioid without abuse, deterrent properties, and for other purposes.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. Are there any bipartisan amendments to the bill? Any amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 4976 to the House. All those in favor shall signify by saying aye. Aye. Those opposed say no. The opinion of the chair, the ayes have it, and the bill is favorably reported. Chair now calls up H.R. 4982 and asks the clerk to report.
H.R. 4982, to direct the Comptroller General of the United States to evaluate and report on the inpatient and outpatient treatment capabilities, availabilities, and needs of the United States.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. Are there any bipartisan amendments to the bill? Are there any amendments to the bill? Gentleman from West Virginia, Mr. McKinley, has an amendment at the desk.
Mr. Chairman, I do have an amendment at the
And the
desk.
clerk will report the title.
Amendment to H.R. 4982, offered by Mr. McKinley
And
and
the
Mr.
amendment, it'll be considered as read. The staff will distribute the amendment, and the gentleman is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. I'd like to thank the majority and minority staff for working with us on this, particularly my friend Peter Welch from Vermont, and on this effort to try to get this included into this legislation. What we're hearing about when we travel around the district and around the country, actually, is the concern for having real-time access to some of this data. And what we're worried about, what we're trying to do is get to that so that people have access to information that's in real time, not something maybe 2 or 3 months late with that. So what this amendment is proposed today is a byproduct of having heard from people around the district and around the country that they want instant information. So our effort here has been, is to give them this real-time data reporting of opioid abuse at the federal, state, and local levels. We can save lives. We can be more efficient in our operation with it. So, in deference to time, Mr. Chairman, I would ask that we support this amendment, and with the hopes that a study can be conducted to indicate the advantages of having real-time, removing those barriers that prevent us from having real-time data on opioid abuse. I yield back the balance.
Yields back. Other members wishing to speak? Mr. Welch.
I thank Mr. McKinley. The opioid scourge has hit Vermont hard. In fact, it was our governor, Governor Shumlin, I think 3 years ago, devoted his entire State of the State address to the opioid catastrophe in Vermont. And I remember a lot of my colleagues asking me why he did that, and was he worried that in so doing it would hurt the reputation of Vermont. And what it did is mobilize Vermont. Our communities have plunged into providing community-based support to help people who have a wicked problem, oftentimes a result of getting prescription medication, like a nurse who injured her back when she was moving a patient and she became addicted, like a 44-year-old hardworking man who was injured in an automobile accident, and he became addicted, and then he died, ultimately, of an overdose. But when I was talking to my colleagues, and when they were asking me about the governor doing this, it became clear that all of us were facing this huge challenge in our own districts. So, Mr. Chairman, I'm delighted that the committee together, Republicans and Democrats are focusing so much attention on a problem that is plaguing all of our communities. This is one small additional element that would provide, as Mr. McKinley said, real-time information that would help our law enforcement get to the bottom of where there are bad batches of heroin and enable them to help stop additional overdoses. So I want to thank Mr. McKinley, and I want to thank the chairman and my colleagues for the hard work that's being done for us to make a contribution to stemming this opioid abuse. I yield back the balance of my time.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by the gentleman from West Virginia. All those in favor will say aye. Aye. Those opposed say no. And the opinion of the chair, the ayes have it, and the amendment is agreed to. Further amendments to the bill, gentleman from Oklahoma.
Thank you,
As
Mr.
an
Chairman.
amendment at the bill, clerk will read the title of the amendment.
Amendment to H.R. 4982 offered by Mr. Mullen.
And without objection, the amendment will be considered as read. The staff will distribute the amendment, and the gentleman from Oklahoma is recognized for 5 minutes in support of his amendment.
I'll be quick. Thank you, Mr. Chairman. It's extremely concerning to see how substance abuse is impacting Indian country. Many Native Americans reside on reservations or in rural areas where drug treatment programs are not readily available. But as we have seen an epidemic on our hands, we need to do something about it. I'm offering this amendment to make sure that the Comptroller General evaluates the availability of residential and outpatient treatment programs for American Indians and Alaska Natives in a report in the report of an opioid treatment infrastructure. We need a full picture of the infrastructure we currently have so we can identify and fill the gaps. I want to thank my colleague, Mr. Foster, for writing this important piece of legislation and for working with me to make sure that needs of American Indians and Native Americans are included in this bill. I yield back.
Gentleman yields back. Chair to recognize gentleman from New Jersey, 5 minutes.
Thank you, Mr. Chairman. I'd like to strike the last word in support of the bill and also speak in favor of this amendment. Research indicates that majority of people in need of treatment for substance use disorders do not receive anything that approximates evidence-based care. And as we've heard from a number of experts who have testified before this committee, a majority of individuals who receive treatment for substance use disorders are receiving care that's ineffective, outdated, and not evidence-based. So each day we're losing lives because of our inability to provide the treatment capacity necessary to deal with this epidemic, and that's why I'm glad to co-sponsor H.R. 4982, which directs GAO to evaluate and report on the inpatient and outpatient treatment capacity, availability, and needs. It directs the agency to examine treatment capacity for substance use disorders across the continuum of care, as well as to examine the availability of treatment options based on reliable scientific evidence of efficacy. In terms of Mr. Mullen's amendment, this is a good amendment. It's going to include in the GAO study an examination of residential and outpatient treatment programs available to American Indians and Alaska Natives through our system of Indian health programs. Unfortunately, we know that significant health disparities exist between Native American populations and other groups. Although no American community is immune from the heroin and opioid epidemic, it appears the problem has disproportionately affected American Indians. According to SAMHSA, American Indians and Alaska Natives report twice the rate of prescription drug abuse compared to Caucasians. Despite knowing these broad generalizations, researchers admit they have insufficient data on the issue of substance abuse in these communities, and this has limited our ability to provide an appropriate response. One study in the Journal of Ethnicity found that access to substance abuse treatment on rural reservations was generally described as scarce, underfunded, or even worse, non-existent. We have to do better, and it's imperative that we supply these communities with the necessary resources. And the first step in combating this epidemic is learning which areas are most in need and where to best target our resources, and this amendment will provide us with this information. So I would urge also support for Mr. Mullen's amendment.
Gentleman yields back. Other members wishing to speak on the amendment? Seeing none, the vote occurs on the amendment offered by the gentleman from Oklahoma. All those in favor will say aye. Aye. Those opposed say no. Opinion of the chair, the ayes have it. The amendment is agreed to. Further amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 4982 as amended to the House. All those in favor shall signify by saying aye. Aye. Those opposed say no. Ayes appear to have it. The ayes have it, and the bill is favorably reported. The last bill of today's markup, The chair will now call up H.R. 3250 and ask the clerk to report.
H.R. 3250, to amend the Federal Food, Drug, and Cosmetic Act to prevent abuse of dextromethorphan and other purposes.
Amendment, the bill will be considered as read, and the chair will ask if there are amendments to the bill. The gentleman from Ohio, Mr. Johnson.
Mr. Chairman, I move to strike the last word.
Strike the last word. Gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. The DXM Abuse Prevention Act, H.R. 3250, helps close the gap in addressing a very serious problem with teen abuse of over-the-counter drugs and medicines. Kids mistakenly think that if it's an over-the-counter medicine, it can't hurt them. Unfortunately, they are wrong. While 10 states have laws on the books restricting sales to those under the age of 18, there is still work to be done in preventing the start of addictive behavior at such an early age. We've had great engagement from stakeholders up to this point, which I thank them for, particularly CHPA, and I look forward to continuing these discussions and refining the bill's language as it makes its way to the floor. Finally, I'd also like to thank Chairman Upton, Ranking Member Pallone, and especially my colleague, Representative Matsui, for their support.
Will the gentleman yield?
I certainly will yield to you, Mr. Chairman.
I want to thank you and the other sponsors for your commitment to this issue. It's one that we have certainly been trying to address for a lot of years. We are moving this bill, hopefully, out of the committee today, knowing that we've got more work today before the floor to do. But I know that the committee and sponsors are committed to working through the remaining issues. We know that kids are abusing these medicines, and it's a common sense way to fix the problem. 10 states already have passed laws just like this one to combat the abuse. We know that many retailers have systems in place. I applaud the private sector investment in these technologies, and this bill will build off of state and private sector efforts to prevent the kind of abuse. So we look for probably a couple of changes yet, but I thank you, and I yield back to you.
Well, thank you, Mr. Chairman, again for your support, and I urge my colleagues to support this legislation, and with that, I yield back the balance of my time.
Gentleman yields back. Other members wishing to speak on the bill? Gentlelady from California, Ms. Matsui.
Thank you, Mr. Chairman. I move to strike the last word. Thank you, Mr. Chairman and Congressman Johnson and Ranking Member Pallone for your work on this important legislation. It's vital that we move forward to address the public health consequences of DEX abuse by teens. I appreciate the feedback we received from stakeholders on this bill. We're working together on a common sense solution to ensure cough medicine remains accessible to those that use it appropriately and inaccessible to those who seek to abuse it. I look forward to working with my colleagues to refine this legislation as we move it out of committee and onto the House floor for passage, as part of our efforts to address the substance abuse crisis in this country. Congress must not wait for tragic stories of children being hurt due to DEX abuse before we act. I urge my colleagues to support H.R. 3250. Thank you, and I yield to the Ranking Member Pallone.
I just want to thank you. I just wanted to thank Congresswoman Matsui and Congressman Johnson for the work on this legislation. Yesterday, I visited a pharmacy, Boyd's Pharmacy in Metuchen, New Jersey, in my district, with the state legislator, Assemblyman Pat Dygnan, who sponsored a similar bill in New Jersey that is now law. And I mean, it was just talking to the pharmacists, talking to others, they just thought that this legislation was so valuable in New Jersey and should be done nationwide. And basically, as Chairman Upton said, we have about 10 states now, including New Jersey, who passed legislation restricting sales of DXM to those 18 and over. And this bill would build on the work of those states and establish the national requirement that retailers who sell DXM have verification systems in place to help ensure that those under age 18 can't purchase DXM, and would prevent the possession, receipt, and distribution of unfinished DXM by entities not registered or licensed with the federal or state government. I know Chairman Upton mentioned that some stakeholders have concerns, and obviously we're going to continue to work on that. But this is really an important bill, so I think I really do want to thank the sponsors, Ms. Matsui and Johnson, for putting this together, because even though some states have it, others don't, and this will just make it easier even for those states that do have it. Thank you. I yield back.
Thank you. I yield back.
Gentlelady yields back. Other members wishing to speak on the bill? Seeing none. Are there further amendments to the bill? Seeing none, the question now occurs on favorably reporting H.R. 3250 to the House. All those in favor so signify by saying aye. Aye. Those opposed say no. The ayes have it, appear to have it, they have it, and it is favorably reported. The committee now stands in recess until 10 a.m. tomorrow, where we're going to take up a dozen bills to complete the markup schedule. With that, we stand in recess.